Okay, good morning again. I'll move along because I know there's quite a bit of pressure on time here. I'm Dr. Brian Marsh, consultant intensive care medicine here, but also chair of the Intensive Care Society Advisory Group on Ebola virus disease. Nigeria has been through the pathophysiology of Ebola virus disease, but the only thing I want to bring, kind of mention in passing, I'm going to put this bit up here, but the actual model of the organ dysfunction as it would impact upon the care of our colleagues at that level of critical care is not terribly dissimilar to many other diseases. The cytokine proliferation, the and anti-inflammatory mediator proliferation, the DIC and coagulation abnormalities that go with that, but also the direct end organ injuries such as the endothelial cells. So as a model, there's aspects that aren't dissimilar, but of course this profound immunosuppression may be desperately important in terms of how the disease progresses. This, of course, is what we're trying to avoid. This is an unfortunate monkey who's been presented. The hemorrhagic lesions, the TK over on the slide A, the forearm. But of course, this would be our feared endpoint of intestinal hemorrhage and ulceration. But as I mentioned before, this seems to be not as prevalent as previously stated and towards the end of the disease, but it does make somewhat dramatic imaging. It's important also to be clear that the amount of critical care delivered to these patients to date has been relatively limited. So knowledge is extrapolating from the cases as they come available to us. But in terms of crisp Western intelligence as to what exactly can be done in a first world intensive care environment isn't crystal clear. But we can learn a lot from what's gone by so far. And this is again from the New England Journal back to this is Liberia. But if you go to the second line here, when would it be best to start to get some intervention that might make a difference to outcome? And you can see the flow down through the number of days, the early pyrexias and malaise and all the rest of it, followed by the nausea, the vomiting, the diarrhea. And here's your big fluid loss time. And then from day 7 to 12, the shock and hopefully the recovery phase. And in so many diseases to intensive care, if you can get that patient before they hit the shock point, that's really going to have an impact on outcome. So I would suggest that should we get a case over here, we'll need to get involved fairly early and assist with this level of volume resuscitation and care which might be required, and hopefully between ourselves and the infectious disease team that will help improve the outcome. We've got a fairly similar report from Guinea, and I'm not going to pick all the pieces out of this, but interestingly, it's not a great huge number of patients, but you see here the median volume of crystalloid. So there's 76% of patients with received IV fluids. The median volume wasn't very high. Now this may impact, maybe it wasn't enough. Maybe that's why the amount of hypoxemia was relatively small at the end of the day, and had they had large volume resuscitation, obviously in the Hamburg case, perhaps you might see rather more of a way of fluid shift and hypoxemia. Nicely, the hemorrhagic level is fairly low. There are these two patients here that they reference with renal failure. Now, the renal failure definition was quite high, 350 micrograms per liter of creatinine. So again, normally speaking in the Western world, we'd have intervened at an earlier point than that, but again, facilities in these societies are very difficult. Looking at the Hamburg case, which is probably the one that teaches us the most as to what may or may not be achievable. Dr. Sheehan has introduced the case description. I'm just going to pick out some relevant pieces to do with clinical care. At the bottom is probably the most important item. I wouldn't encourage you to read the rest at all. But the bit at the bottom is the most important piece. When you're wrapped up in PPE and in a difficult working environment, the amount of direct clinical examination is relatively limited. So being able to use a simple thing like a stethoscope may prove to be very difficult indeed, and indeed impossible, in fact, when you consider the gear, which will be shown to you later on. I've remapped out the Hamburg case just to make it more readable for myself as much as anything else. I find those large tables very difficult to follow. And we're taking day 0 here as in the time of arrival in Hamburg, having come out of Sierra. This is the 36-year-old gentleman. But you see the amount of disease and physiological disturbance that this patient had. The temperature running here from 38.5 or thereabouts from the first day of arrival in Hamburg, right up to 40 degrees centigrade there on the day 3, day 4. And a very slow tapering, but remaining fairly corrective throughout the whole disease. And this coincides with blood cultures on day 4 of the Hamburg part of the stay, which produced this gram-negative bacteremia, possibly related to gut translocation from the very dam of its gut. Quite a resistant organism, as it turned out, but with a huge rise in white cell count at the same time, up to I think that's 28 or so, and associated lactic acidosis. And again, for those of you involved in this type of care, the combination of a big white cell elevation, the shock state, and lactic acidosis will be a harbinger of a fairly difficult time course to follow. And you can see here on the bottom graph, I'll just follow them through for you. This is his heart rate. It starts off below 100, but at the time of bacteremia, it was up to 165, 170 beats per minute. Very sick patient, and remains very sick for really quite a number of days thereafter. Heart rate stays at 120 by day 18 at the Hamburg stage, day 28 of disease at this point in time. He has the initial transaminitis, but in fact this settles fairly quickly. He has initial acute kidney injury with a creatinine of 170 micromole per liter, and this presumably responded well to the large volume resuscitation, which is where the real focus of this patient's care was during the course of disease. Blue here is the thrombocytopenia, which resolved in fact from about day 10 onwards of the Hamburg care. But if you look at the amount of effort that was required to care for this patient, the large graph at the bottom represents the volume management. This is IV fluids, and you can see for the first 5 days of there, it's more than 8 litres per day of intravenous fluids is required to keep this patient stable, to volume resuscitate, to compensate for the very large GI losses, both vomiting and diarrhea. Up to 14 litres there at one stage, so very difficult to manage. Very hard to see how one could manage this in a normal ward environment or indeed a high dependency environment. So tough going to achieve. A lot of electrolyte replacement. This is potassium going in at around about 10 millimoles per hour for this total duration of high volume loss state. So again, difficult to manage, a lot of focus of care. Intravenous nutrition, parenteral nutrition, intolerant gut, as Dr. Sheehan mentioned already. So nutrition became very important very early on. So IV nutrition from very early on, which carries with it, of course, its own implications in terms of care. And the enteral feeding did become manageable later, which was very welcome, I'm sure. And antibiotic management, which I'll not go into, related to the gram-negative septicemia. They ran into considerable difficulties. This is the patient's chest X-ray. Day on the 16th, so that's 6 days into the Hamburg stay. And as you can see yourselves, it's quite abnormal. Bilateral large pleural effusions, atelectasis. They felt that some of this is also related to blood aspiration, so the patient had oropharyngeal bleeding. They were aspirating that bits of blood into the deltoid trachea, again giving rise to atelectasis. And from a patient management perspective, a requirement for non-invasive ventilation for 8 days. And during that period of time, for 5 days of that, the patient's oxygen saturation was less than 85%. So in all our eyes, this is really a terribly sick patient, and they did extraordinarily well to get this patient to survive. It's been mentioned the role of ultrasound, and ultrasound comes into play here in our lives in critical care quite routinely now, both in terms of central venous catheter placement, but also identifying IVC collapse. So it's an important part of what we do, and you can see that they got much benefit from it. So taking all this on board, there's very good information available to critical care as to what we might need to do next. The Canadian Critical Care Society, along with their Society of Emergency Medicine, Medical Microbiology, and Infectious Diseases, published their first version of their critical care guidelines in late August this year. And the most recent iteration, that one of October 28, is available online, and it's very interesting. It's a very good read. What I'd pick out from it mainly is this aspect here, the last sentence, that although robust data is still lacking, anecdotal evidence exists that the mortality rate associated with Ebola viruses can be significantly reduced through provision of supportive care, and particularly critical care. And that's the difficulty in Western Africa. It's a very difficult society to work in, obviously. In Ireland, we've formed the advisory group for Ebola viruses for adults within the Intensive Care Society of Ireland. And as you can see, I've just mentioned it briefly on the left. It involves many of my intensive care colleagues nationally who've advised and put together a resource of information specifically for critical care clinicians, really. It's just to keep them all up to date as to what's changing with disease over time, kind of as an instant go-to resource. But it links obviously straight back into HPSC and HSE and Ireland's Guidelines Central. So what's the scope of critical care overall? Number one, we have to deal with all this in the context of appropriate training, PPE training, and the National Isolation Unit training to make sure that everybody is behaving consistently. The specialist roles are fairly obvious. It's advice, it's assessment of critical illness, early intervention to prevent those organ failures, it's diagnostics such as ultrasound, it's procedural such as placing those central venous catheters which may be required. It's critical care nursing because I can't do this by myself, frankly. The nursing staff are really delivering this care in a very coordinated, well-trained manner. So where do we fit into it? I hope that's reasonably legible. But what I've done is I've taken some of the information from the Canadian guidelines and extrapolated onwards as to what it really means in practical terms. So the hypotension and the shock we've discussed in terms of hypovolemia, maybe a serious response that goes with it, and the need for high volume fluid replacement, electrolyte management, etc. The difficulty on this, of course, is assessing the fluid responsiveness, assessing the volume requirement, the ultrasounds required, the procedural issues required in terms of placement of central venous catheters and the potential risk associated with it, and what's the right day to do that. Is it before they get too sick? When they become more difficult, if they're encephalopathic and agitated, it becomes very difficult. So central venous catheter, it raises procedural issues which we need to address. Vomiting and diarrhea similarly will drive that hypovolemia, but there's a second thing to consider in terms of placement of nasogastric tubes and fecal collection systems, and that in the coagulopathic patient may well cause bleeding in their own right. What about the respiratory failure component? Again, not seen a whole lot today, but the Hamburg case illustrates quite a lot that when you start robustly treating at that higher end of large volume resuscitation, etc., and the patient lives longer and has time to develop their secondary infections, it may become more of an issue. And is that one that requires intubation and ventilation, treatment of bacterial infection? And you can work the rest out for yourself. There's practical issues. How do you deal with the ambu bag? How do you deal with the C circuit? You need to have filtration in line. So that's an important message to get out to people. In terms of the ventilation, the same things arise. Is it better as a non-invasive, is it better as intermittent, as a intubated patient? And again, that's a case-by-case discussion as what's based on the patient at that point in time. Seizures and coma, difficult, but there are issues, sodium, glucose, which can be addressed should they be apparent. We'll get that from the point of care testing. The vomiting and the enteral losses, obviously parental nutrition, but again, it drives the problem about central venous catheter placement. Renal failure, well, that's going to be secondary to hypovolemia and the end organ injury that I've discussed earlier on, and hopefully it responds to the high volume resuscitation that we discussed earlier on. But if it does need dialysis, it is probably the case that given the instability of these patients, that continuous renal replacement therapy, which is really a skill mix of the ICU nursing staff, will be the need. But it's an extracorporeal circuit, and therefore we have procedures in place as to how to deal with that. And there are nice CDC guidelines on how to manage dialysis for these patients. Liver dysfunction, again, coagulopathies, hypoglycemia, etc. to be monitored. Hemorrhage, the obvious, replace the coagulation factors. CPR, well, CPR in every patient is a patient context issue as to where you are at that point in time in your disease and what your own wishes are. So, it's a patient-specific issue. Management of pain seems obvious, but not necessarily that easy. So let's look very briefly at environment. This is the kind of environment that they've generated in the Royal Free in London. Difficult working environment, as you can see, not unless they're expected or tended to nurse on the inside there of the patient. But you can imagine if the patient gets critically ill, how do you deal with all the ancillary materials required to deal with that? This is the Emory environment, which is a little bit more user-friendly, more space, negative pressure, all the flow pathways. This is the National Isolation Unit environment, which is really modeled kind of very similarly on the Emory environment. And in fact, from our perspective, maybe somewhat easier to work with than the Royal Free type environment. My conversations with the Royal Free intensivists is indeed one of concern that working within a Trexler tent is going to be very difficult indeed. Now, unfortunately, when you intensivize it up and the patient needs more and more care, then that room becomes more and more complex. And ICU, as you know, works as a team, so it's doctors, it's nurses all working very collaboratively within a highly trained environment. And we'll have to trim that down a bit because the amount of persons exposed needs to be at its minimum. And it certainly presents a very real challenge. But the patient resuscitative and their care needs, although unique to the disease, they're identifiable and they're within the skill mix of those doctors and nurses. So that aspect of it doesn't concern me hugely. It's the environment which makes it difficult. So the environment and the PPE are complex. And ideally, around that concept, you want one centre only. You don't want a multiplication of care centres in this kind of disease. Now, Dorina pointed up this slide on the left, which is the flow of patients' international travel, and we're all concerned that international travel is terribly easy, and therefore could we possibly get a case? I guess it's possibly true, and we need to be aware of it. It's most likely that will be a repatriation case coming into Dublin Airport and straight from Marsh Hospital, but we have a network of hospitals across the nation. Having said that, it's worth remembering that it's a small nation. And although this is the critical care program, hub and spoke model of intensive care where patients move from smaller hospitals to regional hospitals as their needs require it, I think for this disease in critical care terms, all roads lead to Dublin. And in order to facilitate that, we've also set up a care retrieval service built around this particular disease, which I'm obviously grateful to Carl O'Donnell for really pushing this along in one sense, because it does need a coordinated group of people who know how to work together, and therefore there's going to be training with that ambulance group for that small number of volunteer consultants in intensive care who participate and help manage that, provided that there's an appropriate critical care referral made that defines the disease as requiring that level of impact. And therefore, in closing, I think this is how the critical care Ebola virus disease response becomes. It becomes a different hub and spoke. It becomes that every hospital will, once they have stabilised and resuscitated at PD level, should the issue rise at all, and we really are talking about a scenario where the expectation for disease is very low at this level that I'm talking about, they're coming to the Mater. So the Mater Hospital and naturalisation has become the hub for that new model. So thank you very much.